Hi everyone. This is just a little brief introduction for before your otoscopy prac. I'm sure you've done quite a few exercises now with regards to otoscopy. You should have seen the video where you learn about holding the otoscope correctly and how to examine the ear. You would have worked through the 803 exercises. We're going to talk a little bit again about how to identify the salient features of the tympanic membrane, and we're going to talk a little bit about some of the common pathologies that you might come across. So this is a nice healthy tympanic membrane, and really the features that we're looking for, most prominent will be the handle of the malleus, which is here. The next most prominent feature should be the cone of light. So the cone of light is this here, and basically that's just the light of the otoscope hitting the eardrum and then reflecting back. The cone of light can tell us a little bit about the health and the orientation of the eardrum. You should get that nice sort of cone shape with your cone of light, but if the eardrum is retracted or if the eardrum is bulging, then you do get some scattering of the cone of light. Other features you might see, if you've got a nice translucent eardrum, you might see part of the incus, and you might also see the opening to the eustachian tube, which is the tube that connects the middle ear to the back of the throat. When you're looking in people's ears, it's important to know which ear you're looking in, the left or the right. Basically, if you draw a line from the handle of the malleus to down the cone of light, so as we see here, then that should point back to the posterior side of the tympanic membrane, so towards the back. So if you're looking in the right ear, then it will point that way. If you're looking in the left ear, it will point that way. I actually find the easiest way to tell left from right is to look at where the cone of light is. So in the right ear, the cone of light is on the right side, and in the left ear, the cone of light is on the left. Some people prefer to look at the handle of the malleus, and it creates a bit of an L shape, so L for left. It really depends on the ear, though, as to whether or not that's a salient feature. So I like to use the cone of light, but you will get used to how you like to remember. Okay, when it comes to the colour of the tympanic membrane, there's quite a large variation of normal. So when it's translucent, some light passes through the membrane. When it's opaque, light doesn't pass through the membrane, so you can't necessarily see the bony landmarks behind the eardrum, but opacity is not necessarily pathological. So some people can have quite opaque eardrums and be perfectly healthy. However, if it's red and appears inflamed, then that might indicate some sort of pathology. Okay, so very, very briefly, some of the abnormalities of the external ear and external ear canal. In this picture, you can see that this person has a pinna that's not entirely correctly formed, and they have an absent ear canal. So this is atresia. So absent ear canal is atresia. Malformed pinna is microtia. So this person has a degree of microtia with atresia. All right, it's really, really common to see earwax or cerumen in the ear canal. This is nice, sort of healthy, sticky earwax. It's not particularly old. The older it gets, the darker it gets in colour, and the harder it sticks to the ear canal wall. So depending on whose ear you're looking in, earwax can be sticky and waxy like this, or it might just be dry and flaky. Perfectly normal. There's sort of some variation across people as to what they produce. Okay, another common abnormality of the external ear canal is exostoses. So exostoses is just excess bone growth of the ear canal. So we've got some exostoses here, and they're really quite small and not problematic. Down here, we've got more significant exostoses, and what you can see is the ear canal is growing together, and the sides of the ear canal are about to touch. Now this can be a bit of a problem because you don't get adequate ventilation of the ear canal, and you can get a nice warm moist environment behind the exostoses, and that's a really nice happy place for bacteria and fungus to grow, which can be obviously quite painful for the client. If the exostoses get to this point, then generally an ear, nose and throat surgeon will recommend surgery where they grind away the bone. to remove the excess doses. Okay, otomycosis. This is a really nice fungal infection. Fungal infections are incredibly painful, and you can see some sort of salient features of fungal infection. So we've got a nice fuzzy growth, and you've got little black spores all over it. So this particular client would be in a lot of pain with this fungal infection, but for our purposes, it's really interesting and pretty to look at. So you'd be sending the client direct to the doctor to get that sorted. Okay, one of the things that we do come across reasonably frequently in the ear is foreign bodies, the most common of which is probably the tip of a cotton bud. So we do not recommend that anyone use cotton buds in their ears. They generally don't actually remove earwax at all. What they do is they push it further down. So the external 1/3 of the ear canal is the part of the ear canal that produces earwax. So if we see earwax that is further down, so it's not towards the entrance, then we know that something's gone into the ear to push that down. Generally, when you see the ears of habitual cotton bud users, there'll be a nice impacted wax at the bottom, and it generally has a sort of rounded out hollow, probably little bits of fluff in it, where you can see they've stuck the cotton bud in, they've twisted it around, basically just pushing the wax down, digging out a nice little groove into the wax, and leaving it close to the eardrum. So you don't actually have to remove wax generally. So if you've got a nice patent or open ear canal, the skin of the ear canal grows out from the inside to the outside, so from internal to external, and it carries the earwax out with it. So if you've got a nice open ear canal, as I said, you don't actually have to do anything to remove earwax. Earwax is part of a normal, healthy ear. It can help to keep the pH of the ear canal at the correct point to inhibit bacteria and fungal growth. Okay, so this is a tip of a cotton bud that's fallen off the cotton bud and stayed in the client's ear. So that's not a particularly uncommon thing to see. So we don't use cotton buds. We don't recommend clients use cotton buds. We actually discourage them from doing that. Okay, other foreign bodies. Creepy crawlies, insects, they can all get into the ear. So I don't know what kind of creepy crawly that is, but that's quite nice. Generally, either if an insect crawls into somebody's ear, it'll crawl itself right back out again, or we tend to try and drown it in a bit of water or olive oil to sort of flush it out. You do get all kinds of lovely things crawling in. This one looks incredibly painful, and the ear canal's a little bit red. Look how spiky that thing is, my goodness. Okay, when looking at the tympanic membrane, one of the things that you're going to ask, one of the questions you'll ask yourself is the tympanic membrane intact? This tympanic membrane has a perforation, so a perforation of the posterior inferior quadrant here, and we've got another tiny little perforation there as well. Depending on what's caused the perforation and how big the perforation is, the majority of perforations heal spontaneously and require absolutely nothing from us, except to tell the client to keep the ear dry. So they shouldn't be immersing their head in water. They shouldn't be using anything in their ears until the perforation heals. Sometimes when people have persistent ear infections, an ENT will put what's called a grommet or a ventilation tube in the eardrum, and basically this is a hollowed out tube, which all tubes are, quite frankly, a tube that is placed within the eardrum to keep an artificial perforation open. When you're looking in a client's ear that has a grommet, so typically grommets are placed in children's ears because children are more prone to middle ear infection than adults. You will take a note of the placement of the grommet. So generally what the ENTs do is they place the grommet high up in the eardrum, and then as the days and weeks and possibly months pass, the grommet will migrate down to the bottom of the ear canal, and then eventually when it gets down to about here, it'll be extruded. So depending on how quickly the eardrum is growing, the grommet can be extruded in a couple of months. sometimes it takes sort of 18 months to 2 years for the grommet to be extruded. But the skin of the eardrum grows in a circular fashion, and as it grows, it migrates the grommet down and out. So if you see a grommet up here, it's generally a grommet that's been placed quite recently, and if you see it heading down this way, then it's a grommet that's been there for a while, and it gets down to the bottom and then it pops out and is extruded, and the perforation closes generally on its own. Okay, here's a pathological tympanic membrane. You can see that it's nice and red and inflamed and probably quite painful, and the eardrum is bulging. You can see with the cone of light, it is not a nice cone shape. You can see there's a little bit of light reflected back, but it's not as we would expect. So this person has an infection behind the eardrum, so a middle ear infection. Here is a retracted tympanic membrane. This is a really beautiful example of retraction. It's not always as easy to identify as it is here, but basically you can see the eardrum has been sucked back and it's actually adhered to all of the bones. So this is the malleus, this is the incus here, and this is actually the stapes. So the eardrum is very, very retracted. We don't have a nice cone of light, so this is a right eardrum. We would expect our cone of light here, but you can see that the light is scattered all over the eardrum. Now, depending on how long this persists, it can resolve spontaneously, or it's something that might require treatment. Again, this might be quite painful, but there's no inflammation, so it doesn't appear red, but that doesn't actually mean that it's not painful for the client. Okay, you will have watched the instructional video for the correct otoscopy technique, but the one thing that you must remember is to brace. So brace, brace, brace. Make sure that if the otoscope is anywhere near the ear, your hand is touching the ear as well. So this is correct bracing technique. Do not hold an otoscope like this, okay? You can injure your client if you do it that way. Okay, so that's the end of this short presentation. Have fun in your otoscopy prac.